Okay, everyone, we're going to get started. Welcome to Systematic Psychosocial and Spiritual Needs Assessment and Management with Daniel Cukor. I'm Sherry Sliwa, Project Coordinator for the Coalition for Supportive Care of Kidney Patients housed in the George Washington University School of Nursing. Welcome to the fourth webinar event in our series on supportive care and nephrology. This series is intended to complement a series of articles that Nephrology News and Issues is currently running. Dr. Cukor's article on depression and chronic kidney disease will be published in their June issue. Also look in our newsletter for our next webinar in June with Dr. Daniel Lamb, who will be presenting on implementing supportive care for dialysis patients. Before we begin, I'd like to go over a couple of housekeeping items. For clear reception, attendee lines have been muted. We encourage questions throughout the webinar and ask that you use the chat feature located on the right side of your screen to submit questions. Make sure that when you type in your question that you select all participants and press send. We will attempt to answer all questions during the presentation as we may not have time for questions at the end. You are also more than welcome to submit your burning questions to the Coalition after today's webinar. During the presentation, we'll be asking a few polling questions, so be sure to be on the lookout for these and just submit your answer into that same chat box. At the end of the webinar, as you close your webinar screen, you'll also receive a pop-up evaluation. Because we value your feedback, we ask that you complete the webinar evaluation form. And finally, all webinars are recorded and will be posted on the Coalition website at kidneysupportivecare.org within a few weeks. Dr. Dale Lupu and Dr. Alvin Moss will be serving as our moderators today. Dr. Moss is a professor of medicine in the sections of nephrology and palliative medicine at the West Virginia University School of Medicine. He also is a chair of the Coalition for Supportive Care of Kidney Patients. Dr. Dale Lupu is principal investigator for the Pathways Project, also housed at the George Washington School of Nursing. I'm going to turn things over to Dr. Lupu and enjoy the webinar.
Thank you, Sherry. So we're very pleased to introduce Dr. Daniel Cukor today as our guest speaker. Dr. Cukor is currently the Director of Behavioral Health at the Rogosin Institute. He received his PhD in Clinical Health Psychology from the Fairclough Graduate School. The bulk of his research has focused on psychosocial issues in patients with end-stage renal disease. He has received grant support for his research from a variety of local and federal funding sources, and his current research interests are what bring him to us today. He is currently focused on depression, anxiety, sleep difficulty, pain, and caregiver burden in patients with end-stage renal disease. So we're very much looking forward, Dr. Cukor, to hearing what you have to teach us today. Thank you for running the webinar for us. I'll turn it over to you.
Thank you very much. I appreciate the kind introduction. So today I will be talking about systematic psychosocial and spiritual needs assessment in management. And I have no financial disclosures to disclose, but I'd like to start off with a question to all the participants. Let's see if we can make this work through the chat window. A patient being treated by hemodialysis is markedly more irritable. What is the most probably a symptom of? Is this 1, uremia, 2, depression, 3, sleep difficulty, 4, anxiety, 5, who knows? So for all of you that are able to participate in the chat, if you could just send it in now, it'll be interesting to take a look at what all of the participants think a increase in irritability might be due to. Okay. Just give everyone one moment to enter in their responses.
I've got a all of the above response and a 1 and who knows. People are starting to chat in. So it seems all over the place so far. All of the above.
Okay, thank you all for sending in your comments and your guesses as to what I am looking for here. I guess I will come back to answering this question in a few moments. So here is a picture from an old textbook that I found of common symptoms of uremia, and what I did was I kind of overlaid with it some of the psychiatric symptoms that are common or that overlap with these symptoms of uremia. And you can see that there's a substantial amount of overlap, particularly in the neurological component or section of, as how it's described, between uremia and psychiatric symptoms. So now I have some symptoms, and I'd like you to think about whether you believe the symptoms that I'm presenting are related mostly to uremia, depression, or anxiety. So anhedonia is the inability to enjoy things, appetite change, body pain, difficulty thinking, fatigue, irritability, low mood, muscle tension, restlessness, sexual dysfunction, and sleep difficulty. And hopefully I'm telegraphing this enough that you see that it is really pretty complicated. It could actually be from any of those. It could be due to uremia, depression, or anxiety. So it's common symptoms and complex etiologies. It's hard to know as a physician, as part of the care team, as a patient, as someone experiencing these things, what is this due to? Why am I so tired? Am I just feeling treatment effects? Am I depressed? Am I feeling anxious? Is it a combination of all three? So here is a list of the common symptoms that patients on dialysis report experiencing, and I've highlighted the ones that I think have psychosocial components to it, and as you can see, it's most of them, and these symptoms are really very prevalent. So there's a lot of symptoms in patients, and there's a lot of psychosocial etiologies for the symptoms. There's another study by a colleague of mine, Steve Weisbord and his group, and they identified in 162 patients that more than half of the patients have complaints around symptoms around their mood, sexual issues, sleep difficulty, pain, skin issues, and GI issues. So certainly at least the top four are very related to psychosocial phenomenon. So I'm going to present a case that I'm going to come back to throughout the course of today's talk. So this case is, we'll call him Jeremy. He's not an actual person, but he's an amalgam of cases that we have seen. He's a 68-year-old Caucasian man with end-stage renal disease who's been on dialysis for 10 years. He consistently scored in the elevated range on his depression screens at his dialysis center, but he has consistently refused further referral for evaluation. He is the primary caregiver to his 65-year-old wife, who has serious mental health issues as well as physical issues that limit her mobility. Jeremy tells the care team that he has had thoughts that life is no longer worth living and that he is considering discontinuing dialysis treatment. And given the context of Jeremy's possible depression, his desire to explore discontinuing dialysis was thought of as potentially part of a suicide plan rather than the goal of care conservation, and therefore the nephrologist referred Jeremy for further psychiatric evaluation and was able to get him to agree at that point. So we'll come back to Jeremy, but let's talk about screening. So many dialysis centers now are using the PHQ-2, which is the Patient Health Questionnaire 2, and it's a 2-item inventory of depression. And it is quite straightforward. Over the past 2 weeks, how often have you been bothered by any of the following? Little interest or pleasure in doing things, or number 2, feeling down, depressed, or hopeless. And the patient is supposed to indicate how many days of the last 2 weeks have they experienced those symptoms. And different dialysis centers have different cut points as to where they require further screening or what the next step might be. But here is from the PHQ-2. So they have the probabilities of major depression is the center column, and the probability of any depressive disorder is the column on the right. So sometimes some dialysis centers will use a cut score of 2. Sometimes they use more than 2. So if it's more than 2, you have that person has a 75% probability of having some depression disorder, or a 38% chance of having a major depressive disorder. Just like to point out that even at a score of 1, it is a really high percent chance, I would think, that these people might have some issue going on. And, you know, if this was a different diagnosis, if we thought that there was a 15% chance that they had a diagnosis that we were more concerned about, probably people would be a little more aggressive about following up, even just for further screening. So I don't love the PHQ-2. I think it's a little difficult to understand sometimes for patients. So when I meet with patients and I want to find out if they're depressed, I like the idea of screening for anhedonia or not enjoying yourself and low mood, but I use something that's a little more like this. When was the last time you did something just for the fun of it? You went to the movies, went out with friends or anything, where having a good time was the goal. And then, you know, have them kind of score it in a similar way, not at all, several days, more than half of the days, nearly every day. Or for low mood, do you feel like your mood has been low, like it's hard to be optimistic or see the brighter side of things? How often do you feel this way? And then to get people to rate again on that same scale. So what is depression is, I think, a really good question, and it's not a question that nephrologists only struggle with or patients struggle with. It's a question that I think the field of psychiatry and psychology has been struggling with. So this is from 1973. Depression is characterized by feelings of helplessness, hopelessness, inadequacy, and sadness. However, these are symptoms of several disorders and can also occur in normal individuals. So it's difficult to understand exactly when somebody's experiencing a normal amount of sadness or downness or depression versus an unhealthy amount or a disordered amount of depression, even sometimes for mental health professionals themselves. So the Diagnostic and Statistical Manual 5, which is the newest edition of the psychiatric diagnoses, has two diagnoses in depression that are relevant here today. One of them is a major depressive disorder, which is what we consider depression. And there's a lesser diagnosis called chronic depression. And it used to be known as dysthymia. That no longer is a word that is in use. So now it's called chronic depression. And that really refers to a low-grade, more long-term depression. And then there is another diagnosis, which I think is very relevant for dialysis patients, that is not formally in the depression chapter, but it is called an adjustment reaction, and that is when people are having a strong, either depressed or anxious reaction to a major life change. And certainly I think dialysis, starting dialysis, in fact, would certainly qualify as a major life change. And I think what you see is that there are a lot of people, many people, who really struggle at the beginning of dialysis, and that's probably best characterized as an adjustment reaction, with the hope being that as they kind of get used to the new reality of being a dialysis patient and settle in, those negative feelings will dissipate on their own. So that's usually diagnosed within the first 6 months of exposure to a life change, and then if it sticks around after that, we start to think about some of these other more severe diagnoses. So these are the criteria for a major depressive disorder. You have to have at least 5 of the 9, but the first 2 you have to have at least 1 of the first 2. And the first one is depressed mood or irritable most of the day, nearly every day, is indicated by other subjective report, how people are expressing themselves, or observational made by others. The second one is decreased interest or pleasure in most activities most of the day. So the PHQ-2 just screens for the first 2 questions, and if you have either one of them, they think that it is warranted to go forward and screen further. The PHQ-9, which is the 9-question version, which I'll show you in a few moments, is it just has all of the different symptoms that are there. The other symptoms that are present are significant weight change, 5%, or change in appetite, change in sleep, change in activity, fatigue or loss of energy, feelings of guilt or worthlessness, difficulty concentrating, and thoughts of suicidality. So as you can see, someone who is even coping well, who is now on dialysis, will probably have many of these symptoms anyway. Even if they're honestly and truly not depressed, they still might experience these changes in sleep, changes in their activity, fatigue, difficulty concentrating. So they might have some of the more somatic elements of depression even without feeling depressed. So that's why the evaluation has to be particularly careful to think about, even though there's complex etiologies, all the symptoms that we talked about in the beginning can be due to multiple sources. It is important to get a sense as to what you believe those symptoms are due to. And sometimes it's not either one or the other, but it's a combination of both. And one way to think about it is depression contributing to the amount of fatigue that this person is experiencing? So all dialysis patients experience fatigue, but does this seem in excess to either their normal baseline or to what other people might be experiencing, and why might that be so? So here is the PHQ-9. So it's essentially the same criteria in question format, and this is designed for people to answer independently. They can answer these questions themselves, and again, they're rating themselves on how frequently they have it. So interestingly, the depression diagnosis doesn't ask for severity. So sometimes it's hard to know when you say little interest or pleasure in doing things, how little does little interest be? Number 2 is feeling down, depressed, or hopeless. Well, how down do you have to be to indicate that you're feeling down? So there's no help on that answer. It's really how people interpret it, and the rating is really only for the frequency, not for the severity, which is another reason why these measures are not perfect. So back to our case, back to Jeremy. During the assessment, he was found to have moderate to severe depression according to the PHQ-9, as well as need for support in managing his wife's recent mental health exacerbation and additional help around the house. He refused an antidepressant because he was afraid of the side effects he had witnessed in his wife, but he began cognitive behavioral therapy and accepted the addition of a home aid for his wife. So what we know from before is that dialysis causes a variety of symptoms. It causes sexual difficulty, it can cause sleep difficulty, it can cause pain, it can cause anxiety, and it can cause depression. So a rough estimate suggests that about 10 to 20% of patients may have a diagnosable major depression, and upwards of 30 to 40% may have significantly elevated levels of depressive affect. This is for dialysis patients. And what are the treatments for depression? So they generally fall into 2 broad categories. One is pharmacotherapy, and one is psychotherapy, with the largest evidence base being for cognitive behavioral therapy. So while we know that pharmacotherapy works well, or works in the general population, there actually are very few randomized controlled trials in dialysis patients, and if you added them all together, it's a remarkably small group of patients that have been tested in clinical trials using SSRIs. There are other observational studies that show reductions in scores, so that it seems like they work, but they're not really as rigorous as randomized controlled trials, and people that don't want to be taking the drugs often drop out, and sometimes there's expectancy effects. They might feel the effects very, very quickly, which is probably not due to the pharmacological mechanism, but rather due to expectancy effects. And also, many of these studies have non-blinded assignment, so not only do the patients know what group they're in, but sometimes the treatment team also knows what group they're in, which is a challenge to the methodological rigor of doing these studies. So there are some recent developments in the treatment of depression that I would like to focus on. There's 2 trials that are a bit more rigorous and a bit larger, the CAST trial and the ASCEND trial. So the CAST trial was done by a colleague of mine, Dr. Hidayati, in Texas, in her group, and what they did was they looked at the effect of sertraline versus placebo in patients with stage 3, 4, and 5 and non-dialysis dependent CKD. So they had kind of a simple but yet elegant design where they had a one-week run-in period, and then they had, after that, if you took your doses as appropriate, they kind of randomized you to either placebo or to sertraline. And what you can see here is kind of the main effects from their study. So 10 on this scale, this is the QIDS-C, is 10 is the magic number of where remission occurs. So you can see that, well, the first thing to see is that placebo and sertraline were hand in hand the entire time. There were clearly no differences between the 2. And if you look at the error bars from start to finish, there really was not that strong of an effect. In fact, there was really no difference between baseline and outcome. So a negative trial highlighting that sertraline did not outperform placebo in advanced stage CKD, which was, I think, quite surprising to the community. So we can come back and talk about that again in a moment, but to talk about some psychotherapy trials. So there was a trial in Brazil on 85 participants who were involved in a group CBT immediately before or after their dialysis shift. And they found a stronger effect for CBT than standard care, which was no extra treatment at 12 weeks. And they found that people liked it, they came, there was very little dropout. Here's a study that I did, and this was a crossover design, so people either got treatment first or treatment second with nothing offered in the alternate times. And you can see the blue line is the group of people that got treatment first, so that slope is quite steep. People got better while they were in treatment, and then the second half of the blue line gets, they got a little worse, but they still were under that remission line. And then the red line, so the first half of the red line is before they were in treatment, so I call that expectancy effects. They got a little better, but then the second half of that line, the slope is significantly steeper. In treatment, people got a lot better. And this is depression outcomes. So there's indication that both psychotherapy, cognitive behavioral therapy worked, and this is the most recent trial that just came out. We just published this. It just came out online, I think, in February. It's not really out yet in paper, but the goal was to compare cognitive behavioral therapy versus sertraline for treating depression in patients who were receiving hemodialysis, and it was 41 facilities across 3 U.S. metropolitan areas. It was quite a large study, quite involved and difficult to do, and here are the results. So again, this is the QID-C, the same as the CAST trial. There's the magic number of 10. So this study is not sertraline versus placebo, but rather sertraline versus cognitive behavioral therapy, and they are, as you can see, hand in hand almost the entire way through, and indicating that both of them show the same effect, and they cross from depressed to non-depressed, so both groups can be considered to be effective. And you can see that the lower line, which represents sertraline, the dotted line, perhaps is a slightly greater effect in this study for the sertraline. If we look at on the right side now, the amount of change, so on this QID-C, 2 points is considered to be a clinically meaningful change. So in the cognitive behavioral group, there was a change of 4.1 points, so it's twice the minimal clinical difference. And in sertraline, it was 5 points, so a difference of less than a point between the two groups. But the sertraline did have a slightly statistically significantly more of a decrease. And then if you look at the number of adverse events, though, sertraline had significantly more non-serious events. And you can see with the 17 to 56, so it was 3 times more likely, more than 3 times more likely to have some side effects of the medication as opposed to cognitive behavioral therapy. So our conclusion from this study was that both cognitive behavioral therapy and medication seem to be reasonable approaches to treating depression, and it really comes down to availability of resources. What do you have available for this person, and patient preference. How would they like to receive their treatment? But there's really no clear indication that one of them outperforms the other one. Just a note on why so many people are depressed. So in life, for people that are not depressed, there are many rewarding activities that we engage in all throughout the day. We have social lives, we have romantic lives, we have work, we have praise, and the more you get involved in only being a dialysis patient and your life becomes focused on waking up, going to dialysis, and then recovering from dialysis, and all those rewarding activities begin to fade to the background, who wouldn't be depressed? So, I don't really think of depression as being a non-normative response to being a dialysis patient. I think of it as a pretty normal response, but it's something that still can respond to treatment. So why would you bother? Okay, I'm going to shift gears here for a moment and talk about anxiety disorders. And there is much less known about anxiety and end-stage renal disease. and there is a true lack of precision in the assessments. So again, it's not nephrology is doing. Psychiatry itself is a bit confused about how we understand anxiety. And the DSM-5, which I mentioned before, is the Psychiatric Book of Nomenclature, our big book of diagnoses, which was revised. The fifth edition came out about 6 years ago. So there was a pretty dramatic transformation in how anxiety was organized. So disorders that used to be considered anxiety disorders are no longer considered anxiety disorders, such as post-traumatic stress disorder, obsessive compulsive disorder. They were pulled out of the anxiety disorders and they were given their own chapters. So the anxiety disorders that are relevant to adults are specific phobia, social phobia, panic disorder. Agoraphobia became its own diagnosis, and then generalized anxiety disorder. Let me just say one word about each of them. Specific phobia is a fear of something that is very circumscribed, so something very specific that you're afraid of. It's not a general fear or general worry. And one of the more common ones is a fear of blood, and you could see how anyone who has that common fear might be very challenging for them to be a dialysis patient. Social phobia is a fear of social interactions or social judgment. And you can just imagine if, all of the negotiating that patients have to do, all the forced kind of socialization with the techs, nurses, staff, if you're somebody who really prefers to be alone and not be forced into social situations, it can be very, very challenging to become a dialysis patient. In particular, it can become difficult to advocate for yourself in a hierarchical structure such as the dialysis center, to speak up for yourself and talk to your physicians honestly. So certainly we need sensitivity towards whether patients have social phobia. I mentioned panic disorder. So panic disorder is really a fear of the symptoms of anxiety, is how it is conceptualized, and it is the most common anxiety disorder, and I think it is the most common anxiety disorder that is seen at the dialysis center. All the people that have difficulty at the end of dialysis, as they become more symptomatic, as they're as they're being further dialyzed. So most patients don't like that time. It's difficult for them. They're symptomatic. They have cramps. They have weird feelings inside. That's difficult. And then there's some patients that are constantly signing out AMA, and no matter what you do, they are unable to stay till the end. So I think that's a red flag that perhaps they should be evaluated for panic disorder. Agoraphobia is the fear of being trapped or stuck in an unsafe place. And so many agoraphobics stay home. They don't like traveling out. If you could imagine being agoraphobic and literally being tethered to a machine 4 hours, 3 times a week, it is obviously very difficult. So dialysis treatment can be very hard for agoraphobics. And then the last one is generalized anxiety disorder. So those are your worriers, people that have a lot of mental activity around the future, or around what-if scenarios, and that is for whatever reason, that is it is not the most common one, but that is the diagnosis that we most typically screen for when we are screening at the dialysis center. And I will show you an example of that next, of the screening instrument that is commonly used. But again, I question its utility. So depression exists on a continuum where depressive affect, or the amount of depression that you have, how low you're feeling, kind of runs through all the diagnoses. Anxiety is not quite the same in that it really expresses itself quite differently. But if you talk about the overall prevalence of anxiety, so there's, as I mentioned, panic disorder is the most common one. GAD is probably, generalized anxiety disorder is probably the one that comes next, although there is not very good data in this area, and certainly since the DSM-5 has come out and has separated out agoraphobia as its own diagnosis, I don't think there have been any studies that have looked at the rates in the dialysis center. But as a rough estimate, it is at least as prevalent as depression if you add all the anxieties disorders together. So it is quite prevalent, and the treatment in the community is the SSRIs, selective serotonin reuptake inhibitors, the antidepressants, the same drugs, and also the use of benzodiazepines, so short-acting drugs that will help calm people down, or cognitive behavioral therapy. This is the example from the GAD-7. It's the Generalized Anxiety Disorder 7, so it's brought to you by the same people as the PHQ, so it's the same scale. How many days do you have these symptoms? Feeling nervous, anxious, or on edge, not being able to stop or control worrying too much about different things, trouble relaxing, being so restless that it's hard to sit still, becoming easily annoyed or irritable, feeling afraid as if something awful might happen. So again, it hits upon generalized anxiety disorder, and it is a meaningful way to screen for generalized anxiety disorder, but we have to think about whether this is the best instrument for use in the dialysis center. One of the themes that emerged in Jeremy's therapy was the concern that as his health deteriorated, he would be unable to care for his wife properly. He would ruminate about how distressing it would be for him to watch helplessly if his wife needed more assistance than he could provide. And he was able to state that this fear was so profound that he would prefer dying first and not witnessing it, and even jeopardizing her care, to spare himself the anguish of watching impotently as she deteriorated. But once he was able to articulate the core of this fear and discuss it, he began to think of other ways of advocating for his wife's care that could be within his limited physical resources. So knowing that he could still care for his wife, despite lacking the physical strength to do it on his own, brought him a sense of calm. Now I would like to talk about spirituality and its role within the treatment of the dialysis patient. So spirituality, here's just the definition, it's part of the human experience that gives individuals a sense of transcendent meaning and purpose. If we thought anxiety was ill-defined and hard to figure out what patients' needs are and how to treat them, spirituality is just all that much more complex. So these are some of the common unmet spiritual needs of patients who are on dialysis, needing help finding hope and meaning in life. Sometimes there's a real profound change about what they think their life is about, and helping them reorient and find themselves a new sense of meaning or new sources of hope can be invaluable. Sometimes patients have concerns about death or dying, and often patients are looking for spiritual resources, but they're not really sure about how to go about getting them. So in our depression treatment for Jeremy, one of the things that we encouraged him to do was to break that cycle of going around and around, of just going to dialysis and coming home and not getting out and doing some things that he used to find enjoyable. So what we did was we identified some of the things that he used to do that were enjoyable, and one of the things that he listed was he used to like going to church, but he was no longer able to do so because of his own fatigue and really because of the challenge of bringing his wife with him. So what we did was, even though he had been out of church, there had been a hiatus of several years of his attending church, now with the help in the home, Jeremy was able to attend services more regularly, and he redeveloped the relationships with his friends and the pastor from the church that he had attended before. And the support that Jeremy received from the community helped him reconnect to old friends, to an old community, back to religion and back to God, which helped him find new purpose in his life. So I think the psychotherapy combined with the tangible help in the home, which got him the ability to attend services, helped him renew his passion for spiritual life, and then synergistically combined to give Jeremy not only the emotional energy to continue with his demanding treatment and home life, but to also see his life as having potential for growth and meaning. And he went from being ready to die to having what he felt was a lot more work to do and a lot more things that he would like to do on this earth before that time came for him. So here is a suggested list of steps to help identify and then treat anxiety and depression in the dialysis center. So there are mandated screenings. I guess there's no time frame exactly how frequently those screenings need to be. So I think they should be done at standard intervals, and then they should be done when there's a change in the medical or social situation of the person, or if there's any observed distress, then we should evaluate them. And it's good to start, despite their limitations, it is good to have some sort of documentation of the severity or the intensity of the symptoms. So you can use the PHQ-9 and the GAD-7. Those, I think, are reasonable tools to start the conversation, to start the evaluation. And then I think, an important part is a formal screening, which is not just filling out the paperwork, but someone sitting down and kind of going through that with a person, discussing what their intent or what their meaning of the responses were. And then if they really determine that the person is not distressed and that they're kind of below the clinical cutoffs, so then they can get continued monitoring. They don't require intervention at that time. However, if they do have high distress, if they are above the clinical cutoffs, so then it is very appropriate to provide care in the realms of depression, anxiety, and psychosocial need. So first-line treatments for both depression and anxiety are probably a medication from the category of selective serotonin reuptake inhibitors and cognitive behavioral therapy. That's true for both of them. And then for patients that have other psychosocial needs, supportive counseling, pastoral counseling, self-help in groups are all very powerful interventions for the right person. So I have another poll question. The single best way for my center to treat depression would be 1, medication from a psychiatrist, 2, medication from a nephrologist, 3, counseling done chairside during dialysis, or 4, counseling done through telehealth or video chat. If you are able to still weigh in on the chat feature, that would be helpful. You could send it in, whether you're a patient thinking about yourself, whether you are an administrator thinking about how you'd like to provide this care, whether you're a clinician working with patients. How do you think it would work best for your site to treat depression at your center? So there is great interest and discussion about how this would work best, how this model would get paid for. I think those are all good. It seems like a lot of the answers are coming in are 1s and 3s. So number 1 is the medication from a psychiatrist. 3 is counseling done chairside during dialysis. I am curious, as always, if these are patients who are responding or if these are clinicians who are responding. There's a study that was done which said that patients don't really have a preference as to who prescribes their medication. In fact, if they do have a preference, it's slightly for people who are already part of their treatment team, but nephrologists don't often want to adopt that role of taking on their patient's mental health in addition to their kidney health, so they often would prefer the psychiatrist coming in. And patients generally are pretty comfortable at getting chairside treatment. That's how much of their care is delivered. So even though it seems perhaps like not the most private environment and not the most confidential, most patients would prefer and feel comfortable getting their treatment chairside because they're already there, and the last thing they want is another additional appointment. Okay. So just a couple of practice pointers to go over. Psychiatric assessment should be a standard component of all medical care, and each site needs to create a workflow that identifies key times for screening, thresholds for further evaluation, and then appropriate treatment strategies. I think that seems obvious, but that is not where the state of the care is in this country at this point. So, the dialysis centers are waking up to the need of screening for depression. Depression is an important, maybe the most important mental health issue to screen for. Anxiety is close behind, and then it is not enough to only administer a PHQ or to give out a two-question questionnaire every 6 months. What we need to do is we need to really think about what our patients are going through and then provide resources to them for how to get the care they need. There is considerable amount of overlap between diagnostic categories, and it can be difficult to properly identify individual symptoms. So we have to be thoughtful about our diagnoses. We have to be kind of thoughtful about our patients. Is this something new that they're experiencing? Is this part of their usual presentation? But dialogue amongst the care team with the patient, often with family members, and getting a longitudinal view will often get a sense of what the cause of the symptoms are. Psychiatric diagnoses can represent the extreme end of normative responses, but can complicate the medical course and produce significant burden for the patient and their family and should not be ignored. So while everybody might be feeling less than thrilled about being treated with hemodialysis, there are some people that are more than just less than thrilled. They are really struggling, and those people need to be identified and be offered the help that we can provide them. And spiritual care is a key element of palliative care, and good spiritual assessment of ESRD patients should be able to facilitate improved quality of life. Sometimes the things that that the care team is very skilled at improving are not the things that really matter all that much to the patients, and improving their quality of life, maybe through things that are a little softer, maybe a little bit easier, well, more complex, but more responsive, can really impact quality of life more significantly. So just some highlights. Some form of depression is prevalent in about 30 to 40% of end-stage renal disease patients, with about 10 to 20% with a major depressive disorder. If using medication, SSRIs, or the selective serotonin reuptake inhibitors, are commonly used, but they're understudied. So it is typical to start at a low initiation dose and then titrate up slowly, but unless the patient reaches a therapeutic dose, the medication is unlikely to be helpful. In a study in primary care, so in this country, the majority of SSRIs are prescribed by primary care physicians, and in some very large studies, they found that upward of 80% of patients were underdosed if they're being prescribed by non-specialists. So it's one thing to start a patient, to accept that you're going to try to help them with their depression, but it's usually not a one and done. It is something that requires an ongoing reevaluation and adjustment by the care team. Cognitive behavioral therapy for depression is effective in general populations, seems to be effective in hemodialysis populations as well. I think the greatest challenges there are access to care to well-trained psychotherapists. There's just not enough out there yet. Excessive anxiety is often undiagnosed and untreated in hemodialysis patients. I think that is a pretty fair statement. Palliative care teams should consider the spiritual, religious, and existential needs of patients to provide comprehensive, compassionate care to people with serious and life-limiting illnesses. And I believe the last point is the scientific study of psychosocial factors in end-stage renal disease is really in its very early stages. And despite systematic challenges, there are tremendous opportunities for research and clinical innovation to substantively impact the lives of end-stage renal disease patients being treated with hemodialysis. And I will kind of end this with a call to both the care team, people who are professionals that are in the business of treating patients. There's a lot of room for the creativity and for innovation in how to provide care, what care should be provided. And I also call upon the patients to get involved. We need to create a culture of participation in research. Clinical trials should be a standard part of nephrological care, the way that it is in other disciplines, and the more that culture can be developed, the easier it will be to do some of these larger scale projects, which are really quite logistically challenging because the involvement of so many dialysis centers. So, last poll question is in regard to psychosocial health. My treatment team is 1, is excellent, all the needs are being met. 2, is adequate, basic needs are being met. And 3, my treatment team needs help, not meaning even the basic needs. So if you are part of the care team, asking you to evaluate your care team. If you are a patient, asking you to think about what services are being offered to you. go ahead and weigh in if you would like to.
We have a 2, we have a 3.
Okay, so I mean, I think
We don't have anybody saying 1 yet.
Yeah, that's what I was going to say, that there probably are not that many ones out there. So we all need to be thoughtful as a community and come together to think about why are these needs not being met, and what concrete steps can we take to move forward to begin addressing the unmet needs. So thank you for your time and attention, and I am happy to answer some questions.
Yeah, so thank you. A couple questions have come in on the chat.
Okay.
So one is, comparing the cost of sertraline and CBT, which might be most affordable for the patient?
We did not do a cost analysis as part of our treatment, as part of our study, sorry. So it is difficult to answer that question. I guess it would depend on what type of insurance. Let's say in the general community, both of those are known treatments for depression, so they're both covered by insurance fully. So depending on what type of insurance you have, that may or may not answer the question. If you're talking about costs to the healthcare system, those are much more complicated questions. It depends on how you calculate the cost of antidepressants. If you include all of the development costs, it's certainly higher. If you're talking about just the per pill cost, it is certainly lower. So I guess it's a complicated question, but I don't think there's been all that much interest even yet in the comparison of the two in terms of cost effectiveness until we can really demonstrate that there's reason for people to be thinking about these two types of treatments.
So thinking that most ESRD patients on dialysis, most of them have Medicare and some would also have Medicaid, some obviously have private insurance. Under Medicare, what about to the patient? Is there a big difference, for instance, in the co-pays they might pay for CBT versus medication?
I don't think so.
Great. Okay. Let's see. More questions. Well, I just lost my. Let's see. Question: how might the results of the sertraline versus CBT study look different if done with home dialysis or nocturnal dialysis patients?
Great question. I mean, I think, we don't know. There's a general belief, although I don't think this has really been substantiated by rigorous data, but there's a general belief that patients that are able to get treatment at home have lower depression scores. That might be because the treatment is easier and allows more kind of quality of life functioning, or it might be because we are in some ways cherry-picking the healthiest patients and offering them those treatments, so they're the ones that are going to be less depressed anyway. So it's unclear to me whether there is a significant difference between, let's say, the levels of depression in the two groups. The two groups are different, but if you adjust for that, would the level of depression be different? I don't know. I don't think that has been really investigated thoroughly. And then how would you go about treating it? I mean, I think that the home patients are really ripe for, trying some of these telehealth or, video session interventions, because, they're often comfortable with, kind of getting their care remotely. They like being at home, receiving their care. So I don't know, these studies are all very difficult if you think about the number of patients, that each site has. And then you factor in who's depressed, who would be eligible for a variety of other health reasons, who would be interested. You get down to a pretty small number. So that means you need cooperation of, dozens, if not more, of centers and sites to participate in studies like this. And then the administrative burden just becomes truly daunting and perhaps overwhelming.
Right. So another question. So that's a call for everyone to get involved in multi-site trials. Question: is there a single instrument that can screen for both generalized anxiety disorder and panic disorder?
there are instruments that are out there, so the more general they become, in my mind, in some ways, the less helpful they really are. So I guess to take a step back, it really depends on what you're trying to screen for. So if you're screening for a particular diagnosis, so then you can get very specific about, what the particular symptoms of that diagnosis are. If you're just looking for psychological distress, if you're looking for people who are unhappy because your expectation is that you will follow up with them and then figure out what exactly is going wrong, so there's very short measures of psychological distress that are out there. But they're not really predictive of a particular diagnosis. So if you're looking to begin treatment, or you're looking to have a sense of where this is the interaction is going to go based upon those screening instruments, so then they're less useful, but they might be useful just kind of being a gross measure of this person is not coping well, this person is not doing well with dialysis.
Mm-hmm. Mm-hmm. Another question, what model do you suggest for having CBT available chairside to dialysis patients?
So that is a great question, and a question that I spend a lot of my time thinking about. There are a variety of models as of this point, all untested. I think ultimately we need to get patients the type of care that they would like to receive from the people that they would like to receive it from. And there are studies that show that when you bring outsiders into the unit, it's not well received by patients. They don't want to engage with outsiders, especially about things that are intimate or personal, or they perceive as intimate or personal. They often would like to work within the treatment team. The dialysis social worker, who is the unit social worker, is obviously the frontline person that does all of the mental health work, but they are often so inundated with caseloads and administrative responsibilities that it's not feasible to think of them as providing ongoing psychotherapy with all of their patients. So there are models that exist where the dialysis social worker takes on a few patients at each point in time and works with them in a concentrated way. I think there's other models where there can be other social workers that are added to the team that are specifically trained in interventions that might be available to the unit social worker, for the patients that they are unable to spend the time working through those issues with them.
So just to comment, I won't read all of the comments, but there's a lovely, robust discussion going on about the role of social workers, about caseloads, about splitting between a BSW and LCSW, sort of some discussion around how can we get the social worker more involved in helping with the psychosocial problems. One question, is there any move, let's see, towards allowing a split between LCSW, BSW at CMS or patient advocate groups to allow for some more flexibility? Do you know if there's any change in what's happening in a regulatory way or any advocacy for that?
No is a short answer. I don't know about any changes. What I can say is that for all of our trials, we're pretty careful at recruiting people to do the intervention that are master's level people, because we really want to emphasize that this is a challenging treatment to do, and the dialysis social workers, are really the ones that should be the most qualified to do this type of intervention. And they're not given the time and the space between all of the other demands that they have to treat their patients in a clinical fashion. And I think that, in my mind, that becomes an issue about how the overall structure of how the social workers are being used or utilized, maybe is a better word, in the dialysis centers. And I think certainly, in talking to social workers, there's a lot of suggestions about how they could be better utilized. The way that I understand my piece of that puzzle is, by creating data which shows that if we were to free up their time and we were able to provide clinical intervention, that it actually would be effective and impactful on outcomes that are meaningful to the dialysis center. I think that's a part of the argument as to why this is important.
Mm-hmm. Yeah, and that's some of the discussion. So another question is, do you have any recommendations for pediatric patients in terms of SSRIs or CBT?
Unfortunately, another short answer. Not really. All of the work that we've done has been in adults. There's a lot of research, on SSRIs, and a lot of controversy, I guess, about whether they actually do increase suicidal behavior or not. So I don't really have any specific recommendations for that. Again, it's the same issue, like I said, about the home dialysis patients. Most centers have very few pediatric cases, so to think about doing a clinical trial or even gathering a large amount of clinical evidence would require an unusual amount of cooperation.
Yeah, very difficult. Another question, do you recommend waiting a certain amount of time after initiation of dialysis to administer the PHQ-9, given many of the symptoms can be convoluted with uremia symptoms?
Well, depending on what you're using the PHQ-9 for, if you're looking at it as a symptom of distress, so then there's no reason to wait. If you would like to know if your patients are distressed, whether that be depression or whether that be due to, adjusting, levels of dialysis or uremia. So I think I would still administer it. I think the question is, would I be aggressive at jumping to treatment? So for our clinical trials, we've had a condition that that the patients have been on dialysis at least 6 months, because we know it's a very tumultuous time in the very beginning. So that's for a clinical trial. I think in regular clinical practice, I have no restrictions if people are feeling bad in the beginning. Part of what you can do is you can help them figure out whether this is uremia, whether, very often they're not complying with their diets and they're taking off a lot of fluids, so there's a lot of kind of really dramatic, hemodynamic shifts going on. So that might be why they're not feeling well. And whatever bit we can contribute to that discussion, along with the dietitian, the social worker, the whole care team, that might be helpful.
Thank you. I have a question for you, which is how common is it for a dialysis center to have a clinical psychologist available on the treatment team?
I don't really know. My sense is certainly not very common. Maybe uncommon, certainly. In this country, there really isn't a mechanism for CMS to pay for it. So, it is difficult to figure out whether the additional mental health treatment will have to be provided through the bundle or through some other way of doing some external billing. So that CMS is quite challenging in working in kind of setting up those models. But again, I think by agitating a bit and by showing that the addition of certain extra benefits might really improve patient lives, might improve variables that CMS is interested in, that we could begin to open up the discussion to including some further involvement of other mental health professionals.
Great. Thank you so much. I'm going to summarize some of what, besides your clinical information you've given us, from the advocacy standpoint from the coalition, I heard 3 things. One is we need increased capacity to be able to do multi-center trials if we're really going to find out effective treatment for patients who have ESRD and have some of these less common things. I heard a lot of robust discussion about how do we get our social workers who are already part of the team able to contribute, get them out of arranging transportation and get them actually working on the psychosocial support. Not that transportation isn't important, but we maybe don't need our master's level social workers doing it. And then I've heard advocacy for really looking at a model of care for these patients that looks not just at the blood levels, but looks at their psychosocial and spiritual well-being as well. So thank you so much. Sherry, I don't know if you're going to be able to come back on. I'll just give the are you there to request the evaluation feedback from everyone. On behalf of the coalition, we hope you found this presentation beneficial. The slides and the recording will be up on the Coalition website. And as you leave the webinar, please fill in the evaluation when it pops up. Your feedback is really important to us and helps us in planning and developing webinars that are useful to you. Thank you so much. Dr. Cukor, thank you. We appreciate you sharing your expertise with us.
Thank you.